gives a different residency, though.
Low battery, so I'm going to have to speak quickly. My pleasure to introduce Research Conference today.
Is the mic on?
Well, this one says low battery, so it is on, but it
All right.
hopefully is working for people outside. The recording? Okay, so it's being recorded. So it's my pleasure to introduce Julie Sosa. It's the best we're going to do. She's professor of surgery and medicine in oncology here at Duke, serves as chief of endocrine surgery and director of health services research in surgery. She also, for the DCRI, leads the endocrine Neoplasia diseases group. Gotta get the pronunciation right. Came here just last year from Yale, where she had been there on the faculty for over 10 years and has over 160 peer-reviewed publications, which is belied by her lack of gray hair, and is the international PI for the FACT trial, which is a clinical trial of anaplastic thyroid cancer. So let's welcome Julie and hear her talk.
So I'd like to, first of all, thank the leadership of the DCRI for really the opportunity and the privilege to present to you today. And I'd like to thank everyone in the audience for the courage to come out in spite of the cold weather, and I was glad to see that my lecture didn't get canceled. Today I'm going to talk to you about alternative methodologies in surgical health services research, the road less traveled. And I think that's from the perspective of a surgeon. I think most people in this audience will probably think the methodologies I'm discussing today are quite conventional, but they're quite conventional still in surgery, and we're trying to change that. These are my disclosures, and they really have no relevance to the content of my presentation. So, as I think most people in this audience know, health services research is a wonderful arena to do research, in large part because it embraces so many different and oftentimes complementary research methodologies. However, I would tell you from the perspective of a surgeon, I think still largely health services research is seen to be an equivalent term to outcomes research. And that's because I think the overwhelming majority of surgeons who do health services research do outcomes research, that is secondary data analysis using large, powerful clinical and administrative databases. Certainly, before I came to Duke, the Department of Surgery has a robust reputation of doing very sophisticated outcomes research. These are just some examples of Duke surgeons who have done outcomes research in everything from critical care and trauma surgery to vascular surgery to gastrointestinal surgery, to Judson Williams, who worked here in the DCRI for a couple of years doing cardiothoracic research, and finally my area of interest, which is surgical oncology. I would make an observation that I think there's an ongoing revolution in surgical research, and that there has been a frame shift over the last decade away from basic science and to health services and outcomes research. And certainly those of us who love this kind of research couldn't be any happier. This is the abstract submission profile for our Academic Surgical Congress. So this is an annual meeting, the largest meeting in the world of strictly academic surgeons. About 1,500 people attend every year. And you can see that in 2011, fully 48% of abstracts submitted to this meeting, and there are about 1,000 abstracts submitted, were in basic science. But if you look just 2 years later, there's been significant atrophy in interest in basic science, and really that represents a shift towards clinical and outcomes-based research. So this is the future reality of research in general surgery. And this is actually a program planner for last year's meeting. And you can see that interest in outcomes research was so robust that we actually had to, for the first time, create a parallel track such that outcomes researchers could get together and talk about their science. So what I thought I would do today, because I'm always trying to proselytize things that are a little offbeat and of great interest, is to talk about what we're trying to do in the Department of Surgery, especially as it applies to its intersection with the Duke Cancer Institute and the Duke Clinical Research Institute, and that is to broaden the health services research platform of our department and start to embrace, particularly at the junior faculty and the trainee level, interest and experience in doing some of the other methodologies. And since I only have an hour or 45 minutes to talk to you, I thought I would focus on two. The first is cost effectiveness and utility analysis. And I will just tell you, when I give a talk similar to this one to audiences of surgeons, almost always either people leave the room or sort of give me this kind of Homer Simpson face, and that is, I don't know what you're talking about, and it's all quite scary. And I don't really quite well understand why that is, except to say I think part of the problem is that the lexicon or the glossary of terms that we use in health services research, and particularly, for instance, in cost effectiveness decision analysis, is perceived to be a little inaccessible to surgeons, particularly surgeons who have not had the opportunity to train formally in cost effectiveness analysis or have had the opportunity to collaborate with, for instance, researchers at the DCRI who are quite experienced. So as I think many in this audience know, but I bet you some don't, what is cost effectiveness analysis? So it's really a comparison of alternative interventions where costs are measured in monetary units. Obviously, we're going to be talking about dollars today. And outcomes are measured in non-monetary units like reduced mortality or morbidity. You know, I think when it was first created, perhaps this methodology was inaccessible in that it was created by mathematicians as a managerial technique. But really, its first application made its dissemination much easier in that it was used by the federal government in the 1950s to try to figure out how best to disseminate public dollars for public works. That is, should we spend tax monies on building roads, building dams, or building parks? Applications in healthcare and certainly in surgery are much more recent, and the methodology has been used to help allocate resources across defined competing needs to maximize patient outcomes with increasingly scarce resources. So when you look in the literature, there are loads of applications of CEA in medicine, but if you restrict your search to surgery, there's actually really a very few and scant applications. These were three that I found, and there weren't so many more. One is the application of different forms of anticoagulation for the purposes of DVT prophylaxis. A second is whether ultrasound should be employed to guide central venous catheter placement. And finally, how best to evaluate abdominal pain, what a lot of us in general surgery spend our days and nights doing in an emergency room environment. So these are the really well-known quadrants of cost effectiveness, and even surgeons well understand that any intervention that costs a lot of money but that is poorly effective should obviously be rapidly rejected. Similarly, any intervention that is very cheap but highly effective is one that should be rapidly adopted, but the application of CEA is in that ambiguous middle ground where we need to tease apart fine differences in cost and effectiveness. And of course, conventional definitions, is there such a thing as convention? They are evolving and changing. For many years, $50,000 was identified as a threshold to define cost effectiveness. That is shifting upward towards $100,000 but I would still say, you know, a lot depends on how each culture or society perceives disease and its various management strategies. So before we delve into an example of this methodology in surgery, I think I should expand our glossary one more time and just say, what does an endocrine surgeon do? I get up a lot and people introduce me as an endocrine surgeon and eyes sort of cross and what is an endocrine surgeon? So An endocrine surgeon is a surgeon, a general surgeon, who takes care of the glands in the body. And so those include the thyroid and the parathyroid glands, which we're going to be talking about first, the adrenal glands, and the pancreas. The pituitary gland is the domain of the neurosurgeon, and the ovaries are the domain of the gynecologist. So we do not operate on those organs. So I can't let a talk go without talking about endocrine surgery because it is my passion. So what I thought I would talk to you today about is screening for medullary thyroid cancer. What are the costs and benefits of routine calcitonin measurement in patients who have thyroid nodules? So I know there are probably no other endocrine surgeons in the audience, so let me give you a little bit of background. So medullary thyroid cancer is relatively uncommon. It represents about 3 to 5% of all thyroid cancers. It's a disease that is characterized by early regional metastasis and late distant metastasis, typically first to the liver. It's not associated with radiation exposure, and surgery to this day is really the mainstay of treatment, largely because chemotherapy, radiation therapy, and radioactive iodine are poorly effective. And calcitonin, and this is a picture of the calcitonin molecule, is an ideal tumor marker for this cancer. So calcitonin was first identified in 1968 as a diagnostic tool for medullary thyroid cancer. Normal values are less than 10 picograms per milliliter. Calcitonin level in excess of 100 is deemed to be pathognomonic for the disease. For those patients who have calcitonin levels between 10 and 100, this is an ambiguous region, and we can do stimulation tests with pentagastrin or in the United States calcium to try to discriminate benignity from malignancy. And there is a very good positive correlation between calcitonin levels and tumor burden with medullary thyroid cancer. So what makes a good screening test? Well, it has to pertain to a disease that significantly affects health and has to have a high enough prevalence that it will impact the general population. It should be a situation where if detection occurs in time, outcome will be effective. And there should be some test available where there is an appropriately good positive predictive value. Well, what are examples of successful screening programs? I'm sure everyone knows these, although many of these are increasingly being contested and debated. So mammography for breast cancer, fecal occult blood testing and colonoscopy in colon cancer, PSA, which is under fire for prostate cancer, and in endocrinology, my love, a thyroid-stimulating hormone level for mild thyroid dysfunction. And indeed, if you look at the literature, before we performed our cost-effectiveness analysis, really only one cost-effectiveness analysis had been performed, and this was the landmark study published in JAMA in 1996 by a Johns Hopkins group, looking at the appropriateness of thyroid-stimulating hormone screening for mild hypothyroidism. And what they found is that TSH levels checked at 5-year intervals for adult patients over the age of 35 years was cost effective. When it applied to women, particularly older women, it was less cost effective for men. Why? Because thyroid dysfunction is a condition that typically affects women. So let's turn back to our problem at hand, and that is the patient with the thyroid nodule. So what's the story of thyroid nodules? So the first thing to remember and learn is that thyroid nodules are incredibly common. We think that clinically significant thyroid nodules are found in at least 5% of the US population, and clinically insignificant, that is subclinical thyroid nodules, are found in up to 55% of Americans, with an increasing incidence seen with age. Perhaps the best population-level study was an Italian study by Bartolotta, who found that in 233 patients, there were 711 nodules. Nearly 1/3 of patients had a single nodule, and nearly 3/4 of patients had multiple nodules. So this is an important public health issue. It is so important that the American Thyroid Association has twice issued guidelines for how to optimally manage the patient with a thyroid nodule. The first set was in 2006, the second set in 2009. I'm on the guidelines committee that anticipates releasing the next set of guidelines later in 2014. And according to these guidelines, optimal screening consists of 4 things: physical examination, thyroid ultrasound, TSH, and a fine needle aspiration. In the current guidelines, a thyroid uptake scan should only be used parsimoniously. And these guidelines said the following: they could not advise for or against calcitonin screening because of the paucity of evidence in the literature. So again, this suggests that there is a need for further study in this area. So the first thing we did when we embarked on the study was to turn to the literature to see what was already known. And these really are the definitive studies that have been published in the arena of calcitonin screening, and not surprisingly, they come from Europe and not the United States. This is an Italian study. It's fascinating. It took 2 cohorts of patients. Group 1 patients were patients who were screened with a calcitonin level and who were found to have medullary thyroid cancer. The second group was a group of patients with thyroid nodules who proved to have medullary thyroid cancer who did not undergo calcitonin screening. And you see the most important finding of this figure is that the group that was screened with calcitonin more frequently were found with lower stage disease. So does that matter? Does it matter to be diagnosed when you have lower stage medullary thyroid cancer as opposed to advanced disease? It absolutely does. So this is the survival curves for the 2 cohorts, and what you see is the group that underwent calcitonin screening had long-term payoff of that screening in that they experienced superior survival, and I think both in a statistically and clinically significant pattern compared to the group that did not undergo calcitonin screening. And what did the Europeans take away from this? So these are the practice guidelines from the European Thyroid Association, and they very clearly stated routine calcitonin management in thyroid nodular disease is indicated. So the Americans, ambivalent; the Europeans, definitive, perhaps frequently true in life. So we then looked at the data in the United States and said, well, what is the status of care for patients with MTC in the US? And this was a study that we published when I was at Yale using the SEER database. And this is perhaps one of the most discouraging and disappointing results I've ever had from a research project, in that what we found is that 2 things. Over the course of the last 3 decades in the United States, first, there has been no change in medullary thyroid cancer stage at diagnosis. So we are making no progress, at least that can be measured in SEER, in identifying these patients earlier and thereby potentially affording them superior survival. And secondly, there have been no measurable improvements in survival among patients with this frequently mortal disease. So this led us to formulate our central research question, which is very simple: is calcitonin screening for medullary thyroid cancer cost-effective in patients with thyroid nodules in the United States? How are we going to answer that? So we decided to perform a cost-effectiveness analysis from a societal perspective. So we started by culling base case scenario estimates from the literature for our prevalence of thyroid nodules, MTC, and associated mortality. We use SEER, the US Census data, as well as a comprehensive literature review. We turned to Medicare, the Medicare reimbursement schedule, for our cost estimates, and our clinical outcomes were reported in number needed to screen, absolute risk reduction, and dollars per life year saved, and we did a 2-way sensitivity analysis. So we then employed a decision analysis. I'm sure many in this room are very familiar with this, but for those who are not, and that is frequently a surgical audience, it is an approach to decision making under conditions of uncertainty or ambiguity, with modeling of the pathways of multiple possible strategies to determine which strategy is optimal. And decision tree is a graphical representation of the alternative pathways. So indeed, this was our decision tree. It starts with the hypothetical adult patient with a thyroid nodule, who then is exposed to one of 2 alternative treatment pathways. The first is to undergo ATA guidelines, as stated, but with no calcitonin screening, so the current state of the science in the United States. The second, to undergo calcitonin, American Thyroid Association guidelines, with one addition, that is the addition of a serum calcitonin level. We then performed a Monte Carlo simulation, which is, simply put, a technique of computer simulations. It takes a very long time, which uses sampling from a random number sequence to simulate the characteristics, events, or outcomes with multiple possible values in order to determine the effect of fluctuations of a variable on output values, and it also affords a 95% confidence interval. So these were the base case probabilities that we took from the literature, and actually the literature was quite robust in offering us these, and it includes the sensitivity and specificity of both biopsy and serum calcitonin levels, the prevalence of the disease, how frequently we should screen patients, how long we should screen patients for, and a discount rate. So what's discounting? It's sort of like inflation or an interest rate. It's used in cost analysis to reduce mathematically future costs and benefits to their current value, and these were values from 2011. And typically this is 3 or 5%. We use 3% for this model. So here's how we put in our values, the base case values, and as I explained before, we did sensitivity test range around all of our data inputs. These were the costs that we assumed in the model, and I have to tell you, I do medullary thyroid cancer every day, and this is something I did not know. And I think a lot of my colleagues in endocrinology and thyroidology in the United States are averse to using calcitonin because for some reason they believe that this assay is prohibitively expensive. And what you can see is the reimbursement is at $40, which is not so different from a TSH assay, which, as I told you, is the part of routine screening for mild hypothyroidism in all women in the United States. These were the survival curves, and as you can see, does MTC stage make a difference? It absolutely does. Patients with local MTC have a survival curve not so different from patients in the general population, but when you develop regional disease, shown in green, and distant disease, shown in red, you have significant departure from that curve. So we ran our analysis, and this is what we found. So we found that the addition of calcitonin screening for patients with thyroid nodules resulted in $12,983 cost per life year saved. Well, what does that mean on a population level? How do we digest or interpret this and make it meaningful, say, to the government or to our taxpayers? So we start with the ATA guidelines and we add calcitonin. So life gained is 1.5 years. The additional cost on a per person basis is $40. And if we assume we're screening 10.5 million Americans, that is Americans with clinically significant thyroid nodules, you have an increase in cost of about $730 million. Well, what is the model sensitive to? It's sensitive to a lot of things, actually, and that is assumptions that one makes about prevalence of MTC, the specificity of a fine needle aspiration, which very much varies from institution to institution, the specificity of calcitonin, the cost of the assay, and how long you follow patients for, years of surveillance. Well, what is the population? Should we screen the whole population, or are there potentially, according to this model, subgroups of the population who are most cost-effective to screen? And what we found is that the most cost-effective approach would be to screen men who are young, that is between the years of 18 and 40, with large tumors, that is over 4 centimeters in size, and to elongate our screening interval from the conventional 1 year to potentially 2 years. Well, how does this stack up against other conventional, well-accepted screening programs? Pretty well. These are estimates culled from the literature of the cost effectiveness of various mammography screening regimens, colon cancer screening regimens, and that TSH screening regimen first described in 1996. And you see the calcitonin screening for patients with thyroid nodules is well within these ranges. So what did this lead us to conclude? It led us to conclude that while the results are sensitive to certain assumptions, and that is not surprising, it still appears that this is likely a cost-effective strategy in the United States as it is in Europe, and we recommended that the next iteration of the 2014 thyroid nodule guidelines incorporate this consideration. Where do we stand right now? Well, the jury is out. We'll see when these guidelines are released in 2014. I'll just tell you, it certainly helps to actually be on the committee. Okay, so I'm going to change gears and talk about a second methodology. And it's sort of interesting that I chose this because Doc and I were talking at the beginning of the research conference about graduate surgical education in the United States. And I don't think there is a better place to discuss this topic than at Duke, because as most of you may know, Duke historically has been really the mecca for general surgery training in the United States. It's a privilege to work in the Department of Surgery. And this was a focus of research that I did when I was at Yale, but which is continuing here at Duke. And it employs a different methodology entirely, survey-based research. Again, another methodology that unfortunately surgeons are only starting to employ, but which hopefully we will disseminate more here among our trainees and junior faculty. So the topic is attrition. Attrition during graduate surgical training, or the term residency. What do the data reveal? So general surgery, many people argue, is in a state of crisis right now in the United States, in that fewer people are going into general surgery and its specialties, and fewer people are defining themselves as general surgeons. Well, why is that? Well, I think there are many reasons why this is likely true. One is economic reasons and lifestyle incentives, frankly, reimbursement for general surgery procedures, and medical legal liability is becoming a barrier to practice in many regions of the country. General surgery postgraduate training has faced numerous challenges that have resulted in diminished attraction to surgery as a profession. There's increasing interest in subspecialization, and as a result, today, about 1 in 4 general surgery residents drop out of their training. And this is in stark contrast to other surgical specialties like, say, ophthalmology, which is surgical, where fewer than 1% of their trainees drop out. So this has led many of us interested in the future to worry about what do our workforce projections look like. Well, you don't just look at the end of the pipeline. You have to look at the front end of the pipeline, who is going into general surgery. And these are sort of older data, but nevertheless somewhat disturbing, in that what you see is that fewer students, medical students in the United States, are going into general surgery. And this is particularly true for domestically trained medical students. More and more foreign medical graduates are being used to fill general surgery training slots. Well, leaders in American surgery well recognized this. There was a time of crisis sort of in the late 1990s and early 2000, and it resulted in a revolution in surgical training, the end of the pyramidal system, the imposition of the 80-hour work week, the development of fast-track residencies. And because of all of these things, what we now see is that nearly 3/4 of our residents go into fellowship training. In spite of all of these changes, there has been no repair of that very high attrition rate. So it's like we missed the point. Somehow these changes are not addressing the root problem. So attrition persists despite a strategic redesign of graduate surgical education. Unfortunately, there was a scarcity of data to inform prospectively the changes that were made, and it led us as researchers and educators to say, maybe our strategy should be informed by understanding the study subjects, meaning how do residents feel about their training, and is their perception and set of attitudes associated with their likelihood to complete training or drop out. So this led us to create the NEARS study. Everyone's got to have an acronym. So this was the National Study of Expectations and Attitudes of Residents in Surgery. And what this was a longitudinal analysis over 3 years of all US general surgery residents. And we had 3 objectives. The first was to provide a national demographic profile, really for the first time, of what our trainees look like at a population level. Secondly, to try to characterize a comprehensive range of attitudes, experiences, and expectations from the resident's perspective. And finally, to identify predictors of dropping out. So we sort of started from scratch, and I think we actually did this right. So we did a multi-stage survey development. Our first stage was that we used qualitative methods to identify de novo factors that residents felt were central to training. So to do this, we spent 2 years doing in-depth interviews with residents who actually left training. We explored their training experiences and the reasons for leaving, and after 15 interviews, theoretical saturation was achieved. We then moved into a second stage where we formulated a multidisciplinary, multi-institutional team that used standardized qualitative analysis, constant comparative methods to ultimately construct a 73-item survey, which was then piloted at 3 training programs. We did a factor analysis, and the final result was a 52-item survey on self-assessed performance, ethics, training experiences, and motivations for specialty training. And this is what the survey looks like. And these are just a few examples of some of the questions that we asked. Things like, overall, am I satisfied with my program? My opinions, are they important? Am I happy? Is surgical training too long? So the survey was first administered in 2008, and we, residents, you think they'll do what you ask them to do, but they don't. So the best way to have our survey completed was to administer the survey after the required in-service examination, which is administered on an annual basis in January. It's called the ABSITE exam in surgery. And so this voluntary survey was administered after that exam. Confidentiality was assured. All trainees sitting for the exam were eligible to participate, and the study protocol was IRB approved. And this was the first publication that came out of this study. It was published in JAMA back in 2009, and I would highlight the first author of this manuscript was a surgical resident at Yale. So we had an 82% response rate, which I think is superlative, 5,345 respondents, 248 of 249 training programs participated. We defined a completed survey as one where greater than 80% of items were completed, and there was 92% item completeness, and those are the analyses that we did. And this is the first crude cut that came out of our study, and I think it already started to show very interesting findings. The good news is that the overwhelming majority of residents were indeed satisfied with their program. Well over 85% of residents said that. But then there was some bad news, actually some disturbing news. And some of the bad findings that came out was that a significant proportion of residents had considered, frankly, leaving their program in the prior year, more than 15%. A very large proportion, nearly 30%, were worried that they were not going to be confident enough to be surgeons at the end of their training. Many worried about hurting patients. Many said the hours were causing strain on their family life, and that there was a significant amount of stress at work. So signal was identified in this first sort of crude cut, and what we said was that residents, while overall generally satisfied with their training, there is a substantial minority who reported dissatisfaction, and the question really became, how can we identify these people earlier before they've already decided to leave their programs? And we found the at-risk years were actually not the first year and not the last year, but that middle period, PGY 2 and 3 years. That's 2 and 3 out of 5 years of general surgery training. So why do residents leave? That's the next question. So what's going on? So previous studies, which were all single institution series or surveys of program directors, so not residents, but directors of residency programs once removed, suggested that most of the residents who leave general surgery stay in medicine, but frequently stay in non-surgical specialties. The most frequently cited reason was competing family demands, perhaps not surprising, but that there was thin evidence substantiating these associations. So we took it the next step and said, let's try to identify predictors of attrition. So this was the first comprehensive prospective analysis of surgery resident attrition at a national level. Our intentions were to describe the residents who left, to determine where they left, and to identify why they left. So what we did was we linked 2 databases. The first was our NEARS survey. The second was the American Board of Surgery residency roster, and this is the first time the ABS had shared these data with anyone outside of the leadership of the ABS. And we identified 195 residents who dropped out. We did not pay attention to the 27 who were frankly fired or terminated, and then focused on the 85 who resigned. So we linked the two data sets to focus on the dropouts. So the first thing we found is that categorical resident attrition actually does appear to be highest in year one, that internship year. It naders in the chief resident year, but there is a spike among residents who leave their clinical training to do research, like at the DCRI, in a basic science lab. So these are at-risk people, which I think is very useful. Our cumulative risk of attrition was 19%, so very much in line with that 20 to 25% incidence of attrition that I had mentioned to you earlier. And this is our multivariate analysis that showed that the two strongest independent predictors of attrition were having a child, or this is protective, so a low PGY level, that is internship year. So those were the independent predictors. Now, where did these folks go? So 62% of people stayed in medicine but went into non-surgical residencies. Well, which ones did they go into? And perhaps no one in this room is surprised to hear that most go into sort of quality of life specialties, such as anesthesia, radiology, family medicine, emergency medicine. So that's where they go. Okay, so we said, well, what else is going on here? And is there anything we could do to create barriers to attrition? So one hypothesis we had is maybe if there is a way to facilitate interactions between trainees and faculty, maybe that will help matters. So our objectives, seems reasonable, our objectives were to characterize factors associated with collegial relationships between residents and faculty, to determine the effect these interactions have on resident perceptions, and to identify, hopefully, residents who may benefit most from interventions focused on these interactions. So these were our measures of collegiality. How often do you do things with your attendings on a social level? I feel I can turn to members of the faculty when I'm having problems, and ultimately associating those with satisfaction with the training program. So you've seen some of this before. So 1/3 of residents, which to me seems very small, socialize with attendings. The majority of trainees do not. Fewer than 3/4 feel they can turn to attendings. Fortunately, 85%, you saw this number before, are satisfied with their program. Well, what you see is that for those residents who do not socialize with attendings, they appear to be the residents who feel they cannot turn to faculty with frank clinical patient-related problems. And there's a 3-to-1 ratio between residents who socialize, residents who don't socialize, and the ability to turn to faculty members in times of clinical difficulty. We then looked at resident dissatisfaction with their program and socializing with attendings, and whether they can turn to attendings with problems. And what you see is that there is a clear association of socializing with attendings and the ability to turn to attendings, and ultimately with how satisfied residents were with their training program, suggesting that it may ultimately have an effect on whether a resident will drop out or not, whether they socialize with their faculty. So this was our multivariate regression analysis, and what you see is that sadly there was only one independent predictor of interacting with a faculty member, and that is being a chief resident. So junior residents are the neglected majority of residents who are sort of left out of the party. Other predictors of not interacting with residents, and these are concerns for all residency program directors, are having a fellow, so a fellow intervening between the resident and the faculty. Anonymity in a big residency program, being in a military program, being a junior person, and then to me, as a woman surgeon, being a woman suggests is an independent predictor of not getting together with faculty members. We then looked at factors associated with perceived ability to turn to faculty members in times of difficulty, and here there was just one independent predictor of that, and it is being a woman resident. So almost 2/3 of residents do not socialize with faculty, and over a quarter feel unable to turn to faculty with problems. And I don't get down about this, I just think this is a call to arms. Program dissatisfaction is associated with limited social interactions and an inability to turn to faculty, and women have fewer social interactions. And then a final example of some of the work that has come out of this study, which is ongoing, is the intersection between race and surgical residency. So here we wanted to try to determine how race, the race of the resident, not the faculty, influences resident experiences during residency in 4 major domains: fit with program, faculty relationships, peer relationships, and surgical training. And the first thing we learned, and I think this is really the first time this has been shown on a population level, is that our population of general surgery residents in the United States in no way really reflects the general population of the United States, in that there is a paucity of Black, African-American residents, Hispanic residents, and actually overrepresentation of Asian residents. We then looked at resident factors associated with program fit, and what we found is there were 2 that suggested poor fit. One, and these are both independent predictors, one being sort of an older resident, someone who maybe took time off before going to medical school or college, and being Black. Unfortunately, we did not collect data on the race of the faculty members, and it's one of my many regrets. We then looked at resident factors associated with additional specialty training, meaning they don't feel they're ready to be a practicing surgical consultant, and I got to do more because I'm not confident. All of the minority residents, Black, Hispanic, Asian, and other race, felt a greater need to do specialty training after their residency as compared to white residents, leading us to observe that compared to whites, minorities report less positively about program fit and working relationships with faculty and peers, and less satisfaction with their surgical training, and feel more need to pursue postgraduate specialization. So what do we do when we put it all together? I think we need to say that resident attitudes are incredibly important. We need to listen to our residents, because these attitudes, perceptions, should be incorporated into the policy we make as surgical educators. I think that at-risk residents, we've identified minorities, we've identified women. On face, it has validity, but this is really the first time I think it's been shown at a population level, would benefit from targeted interventions and additional support structures, and we need more, better studies than our study to answer these kinds of questions. I wanted to finish by really acknowledging several teams. So I've always, in surgery, I think people who go into surgery very much subscribe to the belief in working as a member of a team. An operating room only works when you function collaboratively as a team. So this was our team for the NEARS study. It includes Dr. Bell from the Board of Surgery, Heather Yo, a Robert Wood Johnson clinical scholar and resident who worked with my group, medical students, faculty, and surgical residents. Well, what is my team here at Duke? So I have a new team, and I wanted to acknowledge them. So this is Duke Endocrine Surgery, the gland surgeons at Duke, Sanziana Roman, who came with me from Yale, Randall Sherry, who like me is a surgical oncologist. All of us do health services research, so we're health services research heavy in endocrine surgery. And this is the Endocrine Neoplasia Diseases group. It is a young group. It's just a year old right now. My colleague and friend, Shelby Reed, I feel blessed to be working with her. Michaela Dinan, equally blessed to work with her. Our program manager, programmer, and we already have these 3 trainees working in our group. We have another trainee who will be joining us for 2 years, and I am proud to say we have just received word that the Italian government is going to be funding our first international endocrine neoplasia diseases group research fellows starting in May. A lot accomplished, a lot left to do. I'm very excited to be here, and thank you for the privilege of the podium.
Thank you. Questions?
What you think needs to be done in terms of academic surgery being incentivized to help develop further research programs. One of the things that comes up frequently is when you look at health systems or academic medical centers, the surgeons are often incentivized by the volume of cases. And it's actually been an interesting conversation when we have opportunities in terms of those types of trade-offs. Is that a true assessment, or is that something that's just unique in terms of some of the different subspecialties?
No, well, my first observation is I think with the shrinking resources and funding available to all of us as academic physicians, I think that is a theme that is by no means surgery specific. It may be more acute because for several reasons. One, salary points, where they are in the reality of you got to make your salary, whatever your salary is. Secondly, I think there is perhaps less precedent in American surgery for a phenotype of someone who does research primarily. And I think the reason for that is if you don't operate, A, you potentially lose your skills, and B, and I think this is true at least at the highest levels of academic surgery, you lose some credibility among your colleagues. If you are not an operating surgeon and you are a scientist, somehow you are not one of us. You are a different phenotype, and advancement is disabled. And I think the last thing is perhaps a lack of mentorship as a result. So if you are a general surgery trainee and you look around you and you don't see anyone who has succeeded before you, especially if you're a minority resident, especially if you are a woman resident, why do it? It's too high risk. Is there precedent for this at Duke? Certainly, Chuck Scales is here. There is. One of my goals is to try to grow this population of trainees. And I don't think there is at all a lack of interest. I would say it is a lack of opportunity and the need for courage. And I think if you see a mentor or you see examples of others who have succeeded, I think others will follow.
Sorry, I had a comment there.
Dr. Peterson's speech.
The microphones are in the ceiling, so just speak up. Go ahead.
Julie, I really appreciated your talk. Having just finished up a term on the board of directors of the ACGME and chairing the resident council, your findings from this resident survey of general surgeons really resonated with all of the opinions expressed by my surgical colleagues across many specialties. And in particular, this feeling that in the era of more and more professional duty hour restrictions, this feeling of reduced case volumes and whether or not people are sure about they're ready or not. In general surgery, to what extent do people, once they finish general surgery, are able to do specialty-focused training or specialty-focused practice, as opposed to the need for going on and getting fellowship training to become an endocrine surgeon, for example, and really having a very focused practice with that? And how does that influence your results, do you think? So in other words, the need for I just don't feel comfortable anymore training versus I want to be an endocrine surgeon and focus really on that.
Yeah, I think there are many good features of our survey, but it's a pretty crude sword. It made some broad observations, and I think the kind of more sophisticated and refined question that you have demands a much better answer than I can offer. What is certainly true in general surgery is that fully 77% of residents go into specialty training now. When we asked in our survey why is that, there were a couple of themes that emerged. The first was lack of confidence. So likely because case volumes have shrunk. When I finished with 1,500 cases. Residents now can finish, I think, with 500 is, many would say that's barely adequate, and certainly not adequate to do complex specialized surgery like endocrine surgery or whatever. I think to finish as a general surgeon in the United States, you need fewer than 8 cases in endocrine. So I think one is a lack of confidence. I think a second theme that emerged was an association between specialization and improved quality of life and reimbursement. And I think this is true. I think if you are a specialist in the United States, your quality of life is better and that you can avoid transplantation or a specialty like that where emergencies in the middle of the night are very common. And also clearly reimbursements are much higher for the specialty services than for general surgery. So I think those would probably be 3 themes I would point out from our survey, but that is super crude and totally not adequate. And so my observation, the one call I say to everyone when I give this talk is that I think it is so important that before we make additional policy changes in American surgery pertaining to graduate surgical education, we have to collect the evidence that will inform them such that there are repercussions, i.e. the attrition rate falls. I think the problem before was that changes were made that were good changes, but not necessarily informed by the people most affected, and that is our residents. So I just think we need to pause, collect data, and then move forward incrementally.
Other questions, Eric?
I will make a couple comments and maybe end with a question. The couple comments are, first, thank you for that presentation. It was a great kickoff to 2014, and I think you brought to the DCRI a renewed energy in surgery that we haven't seen since Bob Jones' era. Just a few years before. But it really is impressive to see, and I like the degree to which you're filling out, in part, themes that are going to transcend across multiple different fields. The types of things you're looking for and the ways you're setting up both research domains and mentorship is exactly the same model that would work anywhere in surgery, and frankly, anywhere across the campus in areas where there's a relatively small cadre of researchers working in a given area. So in that regard, they do need mentors, they do need general skills, and then they need to specialize that for the area of interest that they're talking about, whether urology or ophthalmology or endocrine neoplasia. But the same concepts of cost effectiveness of survey or health services research is going to carry across all those pretty darn well, and a few good mentors at the top could go a long way in helping to that field forward. So I guess my end question is, what does it take for this to expand more broadly in surgery at Duke?
Yeah, so my first observation is that, I'm very much a learner still, and when you come to a new institution, you can't be a bull in a china shop. You have to be, I think, very respectful of the domain and the milieu in which you're working, and honor sort of themes, but at the same time try to elicit changes that you think are for the better. So the footnote for what I'm about to say is just that I'm a newbie, so don't kill me. What I think is that there is great interest and hunger, okay, in the Department of Surgery. There's no question in my mind. You saw the data from the Academic Surgical Congress. Most of the attendees to that conference are trainees and junior faculty members. So the future, I believe, of American research is largely based in clinical and health services research. So the appetite is there. So why aren't there more people? I think one is models and mentors, and American surgery is a little behind some of our sister disciplines in terms of progress made with regard to formal training, mentorship, all of these things. So surgery's maybe 5 to 10 years behind others, but rapidly catching up. So I think we need more time. The third is no man is an island. And, and you and I have talked about this many times, is the mentorship I am talking about is mentorship not just in American surgery or Duke surgery, but outside of the Department of Surgery, where we forge collaborations and networks with people who are relative experts to us, because I am by no means a methodologic expert in anything, and I know that, and I hope I know my weaknesses, but forging opportunities to collaborate with others. And my observation is, I've been at Hopkins and Yale, so I only have 2 comparison institutions, Neither of those institutions made it very easy. I have found it in the last year much easier to collaborate and find colleagues and friends outside of surgery than I did in 22 years at either of those institutions. And I'm not kissing up, this is the truth. And I'm the same person, right? So it's not me, it's not here, it's somewhere around me, right? And I think it's just having the passion, finding the right group of people, and then pushing forward. So that's what I think I would say for the future.
Thank you very much, Julie.
Thank you.